thanks for coming out tonight. I guess we're in competition with the debates, so for those of you that are here, thanks for coming. But hopefully, this our little presentation will be on our website available. They're going to record it, so that'll be good if you wanted to reference it later or share it with friends. Anyone who has questions. The reason we wanted to put this on is because even though seemingly to us, hormone replacement therapy and menopause is such a common thing, but there's still a lot of women out there who, don't realize that the symptoms that they may be having are related to the menopause, because there are, in addition to the kind of basic hot flashes, night sweats, there are a whole host of other symptoms that can happen. And women don't realize that these can happen even when you're younger. So, and I actually was guilty of that myself. Being this is what I do for a living, but yet when I was having symptoms at 42, I didn't think about it right away. And then finally
me at 38.
Okay, so then a year late, about a year after that, I'm like, oh yeah, okay, maybe it is that. So certainly if we're not even thinking that it might be that, most women probably aren't. And then on the provider side, there are so many physicians who are unwilling to prescribe hormone replacement therapy. And that's because I think they are going off old data. The WHI, which is the Women's Health Initiative that was published in 2002, scared more than half of the women off their hormones, and I think scared a lot of physicians away from prescribing hormone replacement therapy. So we wanted to kind of clear the air on that.
Right. Yeah, we just hate for women not to consider hormone replacement therapy when they might have the wrong information and be falsely afraid of taking it.
Right, especially since it's so effective and the alternatives aren't as effective, right? So, you have something like mood changes. And I've had many patient come in who was offered Prozac, that's not the answer. And I think hormones are definitely a better way to go there, because they will address so many more problems, instead of having everything kind of be piecemeal, for each separate symptom. So actually starting with, that's a great segue to go into our questionnaires that we have. So number one, which of the following symptoms are symptoms of the perimenopause or menopause? And so let's just go over each one of those, and you guys can say yes or no. Hot flashes,
Yes.
an obvious one, right? Night sweats,
Yes.
irregular periods,
Yes.
Decreased libido,
Yes.
painful intercourse,
Yes.
anxiety, depression,
Yes.
poor sleep,
Yes.
fatigue,
Yes.
weight gain,
Yes.
joint pain,
Yes.
headaches,
Yes.
palpitations,
Yes.
dry eyes.
Yes.
Yeah, even dry eyes. So yeah, so this is what I mean by the symptoms are kind of, all over the place. And, it may not necessarily be menopause or estrogen, progesterone related, like fatigue, weight gain, for instance, right? We have to consider thyroid. So we're going to do a full evaluation to rule those things out too. But, but definitely, menopause should be in the differential diagnosis for what could be the cause of these symptoms. Okay, let's see, let's just go on to number two. Or does anyone else have any other symptoms that they might have had that they're that you're wondering may be related to menopause or anything like that? Okay. Number two, cardiovascular disease is the leading cause of death in women over age 40. True or false? Yes, it is true. So cardiovascular disease is actually, yes, the leading cause of death in females age 40 and over. I think before the age of 60, your risk is twice that of death from breast cancer. And then when you get into older ages, you're looking at 4 to 6 times greater than dying from breast cancer. Yes.
Doctors, just for the for our audience listening at home, if you could just speak up a little bit louder.
Oh, okay.
Thank you so much.
Sure. So, and we'll segue into why this is important. because we want to, we want to be able to provide patients with guidance on how to prevent cardiovascular disease, since it's really, one in two women are going to die of cardiovascular disease. So you hear scary numbers like breast cancer is 1 in 8, dementia is 1 in 5, women. Cardiovascular disease is 1 in 2. So that's a thing, that's what you should, really be worrying about, right? So obviously at Test and Longevity Center, we, counsel you on proper diet, exercising adequately, and sleeping enough. All of these are very important in preventing cardiovascular disease. But hormones too have been shown to decrease your risk, anywhere from 30 to 50% decreased risk for cardiovascular disease. And so we'll go over some of the literature on that too. That is that's my number one thing that I'm thinking about for especially for postmenopausal women. Number 3, true or false? Breast cancer is the leading cause of death in women diagnosed with breast cancer.
You think once you're diagnosed with breast cancer, you think you're most likely to die of breast cancer?
Depends on when people can, detect or work on.
Right, it does depend on your
Depends on the
stage.
stage of
Yeah.
disease, but
Yes.
most are caught early, and most women don't die of breast
Correct.
cancer, they die of
Yes.
something else. later on.
Right, and actually that something else is usually
Cardiovascular
cardiovascular disease, yes. So cardiovascular disease is the leading cause of death in women diagnosed with breast cancer. So interestingly, yes, there's a lot of the breast cancers now are detected at early stages. So the 5-year survival rate is actually 90%, kind of on average. Obviously, the later stage you are, that survival rate is going to be much lower. But because most are being diagnosed, like even the in situ, the carcinoma in situs, those are really stage 0. That's like 98% 5-year survival rate. So the reason that this becomes an issue is because, once you're diagnosed with breast cancer, then you have women being taken off their hormone replacement therapy, right? Because of the belief that it is going to cause the cancer to recur. But you really, when you do that, you're kind of denying the women the cardiovascular protection that you can get through hormone replacement therapy. I guess I'm kind of jumping around. Maybe we'll go through all the questions, and then that way it'll make more sense. For true or false, the WHI, which is for A, true or false, the Women's Health Initiative, the WHI, proved that hormone replacement therapy, BHRT, causes breast cancer. Yes, the answer to that is false. And again, I will go into that, but let's go down the line here. 4B, true or false? The WHI found no improvement in quality of life for women on hormone replacement therapy. So the quality of life issue is basically, how you have patients usually presenting with menopausal symptoms, like they're having hot flashes throughout the day, night sweats, they can't sleep, and so because they can't sleep, they're irritable, they're tired, that kind of quality of life, okay? So true or false, the WHI found no improvement in quality of life for women. Okay, so this, and I'll go into why this is the answer after we go through all the questions, but they actually did find no improvement in quality of life for women on HRT. I will just asterisk that by saying for their study population, and that's where the difference is, okay? Okay, number 5, true or false, there is no need for HRT in the treatment of osteopenia or osteoporosis because alternatives such as Fosamax and Evista are equally efficacious. False, definitely false. Number 6, true or false, HRT has been shown to decrease dementia and Alzheimer's risk by 24 to 65%. So it's depending on the study that you look at. True. Yes, that is true. And number 7, true or false? Several studies have shown no increased risk of stroke in HRT users who start hormones within 10 years of menopause. That is true. Okay, so if you're starting hormone replacement therapy before, within 10 years of menopause, no increased risk of stroke. And that the within 10 years of menopause is what what's known as the window theory, which is basically, well, I say I'm getting into the WHI again, but I'll just say, so in the WHI, one of the main problems with that study was that they used a much older population, like I think the average age was 63. So that's really, like most women start hormone replacement therapy either around menopause, which is roughly on average around 51 or earlier or a little bit later. But these are women who've been, out of menopause for 10, even 20 years, okay? So there is a difference there, potentially. Okay, and the last question, number 8, true or false, HRT increases the risk for breast cancer recurrence, which is why HRT is withheld from women who have had breast cancer. False, yes. Okay, so yeah, do you want to go over
Keep
your
going. I
questions?
think keep going with your idea because then,
Okay.
yeah.
Then we can segue to yours. Okay. So yeah, so basically, I want to talk about the Women's Health Initiative because, like I said, that was the study that came out in 2002, from which a lot of physicians are basing their decisions on whether or not, or usually not, to treat with hormone replacement therapy. And there were, they had stopped the study prematurely. They had stopped it after only 5 years because they stated that there was an increased risk in breast cancer. And so that was so important that they had to stop the study. And then they made their conclusions and they stated that, based on the conclusions from this, that this is how we should treat, we should make our recommendations for hormone replacement therapy. Yes, this is what we should do. Because they claimed all these, that this was a healthy population. Well, as I mentioned, the average age of the woman in the study was 63 years old. So these are women who are 10 years postmenopause already. And we'll get into why that may make a difference. About more than half of the women were either obese or overweight. About half the women were either current or former smokers, and about 30% had high blood pressure. Okay, and then there were some in there who were using statins, some in there who were using aspirin. So it wasn't exactly what we would call a healthy population, okay? But let's assume that it was. Let's assume that it was. And the reason I say that is because if you look at the statistics that they used in this study, it was not statistically significant, basically. For first of all, the paper states that they use one set of statistics, which actually don't even pertain to the study, because a set of statistics that they use would only be applicable if you were only measuring a single outcome. But the WHI looked at more than one outcome. They were looking at your cardiovascular disease. They were looking at different cancers, breast cancer primarily, breast cancer, endometrial cancer, colorectal cancer. They were looking at hip fractures, vertebral fractures. So stroke, venous thromboembolism, blood clots. So you see, they're looking at multiple parameters. When you look at multiple parameters, you cannot look at a nominal confidence interval, which is the statistics they were using. You have to use the adjusted confidence intervals. And when you looked at the confidence intervals that were adjusted, the ones that you were supposed to look at, because this study looked at multiple factors, the only thing that was statistically significant was the increased risk for blood clots in the veins, which we already knew. Because the patients in this study were using Premarin, which is an oral estrogen, and they were using Provera, which is medroxyprogesterone acetate, it's a synthetic progestin. It's not bioidentical progesterone. So the combination of that synthetic progestin and the oral estrogen does increase your risk for blood clots in the veins. We know that already, so they didn't really show us anything different from that. No, they confirmed it, okay? So, it is, so it is sometimes, it's mind-boggling to me anyway, that this actually got published in JAMA. Like, where were the people, like, someone should have been able to look at these statistics and say, these are not significant.
This is not good science.
Yes, exactly. So, if anything, I would actually say the opposite. I would actually say, even in this population of women who are older and, who are not exactly the healthiest, you didn't see an increase in breast cancer risk or cardiovascular risk or stroke. So that's how I choose to interpret it, because that's what the statistics say. Okay, and the reason that is so upsetting is like 50 to 70% of women came off their hormones in that year, and it never really quite fully got back up to, where the number of women that were taking the hormones, that just hasn't recovered, even though subsequent analyses of the WHI actually showed no increased risk. Like, they eventually ended up saying that later on, like even 5 years later in 2007, their paper said, actually patients on hormone replacement therapy have a decreased risk of cardiovascular events. But did that make the headlines? No, right? I think with the news being as sensationalist as it is, you only want the bad news, right? It causes breast cancer or it causes heart disease. Why wouldn't you want to say it lowers heart disease risk? That's great, But anyway, that's journalism. So if you look at, before the WHI came out, if you looked at the body of evidence before that, and this is actually where people were trending, we had a lot of women on hormone replacement therapy because there were plenty of studies, observational studies. There were some randomized control studies in there too, that did show that you had a decrease of cardiovascular risk. You had a decrease of dementia and Alzheimer's, 24 to 65%. So versus something like breast cancer, which, I think is especially scary for women, even though the numbers don't bear out like why you should fear that, because it's not the most common cause of death, but it is something that's scary for women. But like I said, the 5-year survival rate is currently 90%, right, for breast cancer as a whole, versus dementia. There is no cure for dementia, right? So we're really looking at prevention, okay? Sleep is a huge one for that, by the way. Getting a minimum of 7 hours of sleep is very important. Anything else? Oh, okay, actually, so breast cancer recurrence. So that's a huge one, because very often women are going to come off of their hormones when they're diagnosed, and then a lot of them have a miserable quality of life, because then they start getting the hot flashes and the night sweats, the fatigue, the moods, all that stuff, and they're suffering through that, but their physicians are hesitant to put them back on hormone replacement therapy, especially if it's an estrogen or progesterone receptor positive breast cancer, because they're afraid of, causing a recurrence. So that's interesting. The whole idea of estrogen progesterone receptor positive, people think that means that the estrogen and progesterone cause the breast cancer. That's not what it means. Your breast tissue is supposed to have estrogen and progesterone receptors, right? Like, we know that when you take hormones, it stimulates your breasts, like when you're pregnant and your estrogen and progesterone levels go, your breasts get larger. You're supposed to have estrogen and progesterone receptors. And actually, if you look at breast cancer where the estrogen and progesterone receptors are negative, those actually have a worse diagnosis. because the tissue is abnormal, right? You should have receptors. Why don't you have them? So anyway, so data, they have looked at data in breast cancer patients, and they have shown that there is no increased risk of breast cancer. There is one study out of the many. I mean, if you look at all of the data in the 1990s, no increased risk. There was one randomized control study called the HABITS trial that did show an increased risk, but that was the only one. A similar study with about the same amount of women came out at about the same time that showed no increased risk. And so there were some questions about like why did that study show some increased risk and the others didn't? And that had to do with the way the study was set up. There was no standardization in terms of like what the women were receiving in terms of hormone replacement therapy. It was kind of all over the place. And then also they weren't, they didn't get a mammogram before they entered the study. They weren't staged prior to the study. So the question is, maybe there was already some disease there before the study that may have not, that may have influenced those results. But I think the bottom line is if you look at the majority of the studies, you're going to find no increased breast cancer occurrence. And the way, one of the books that I put on the reference here is Estrogen Matters. This is a book written by Avram Blooming, who is an oncologist, and Dr. Carol Tavris, who is a social psychologist. So they have this is a very well-referenced book that came out fall of last year. So that's what a lot of my presentation is based on tonight. So what he actually did, looking into this question of whether breast cancer recurrence is higher in women, was he looked at all the studies, looking to see if removing the ovaries after breast cancer reduces your risk of recurrence, then okay, that would be a sign that maybe estrogen or the hormones do cause a recurrence. But he found in the studies that there was no improvement. You got no better result from having your ovaries removed, okay? And then the other thing he looked at was women who became pregnant after having breast cancer. Were their recurrence risks any higher? Because again, pregnancy, very high estrogen, very high progesterone levels. So if the hormones cause a recurrence, you would see it in that population, and they didn't. So it's a fantastic book. I would highly recommend it. And I also did put on the reference under the references that where you can find the Women's Health Initiative, so that if you wanted to kind of look through it, you could too. Okay, I think I've talked enough, and I don't want to talk at you. I really want to have a lot of time for any questions that we might have from the audience, live and otherwise. I'll pass it over to Dr. Meric.
Okay. And you want to do that in that order, or take questions for you first?
Oh, well, whichever. Do you guys have any questions right now?
I guess one of my questions would be, would you ever consider going on HRT if you have a high risk of cardiovascular disease, say in your family or whatever? Like, would you choose that to lower it?
I would. Currently the recommendations, they're still looking at, there are actively some randomized control studies going on right now, like the KEEPS study, which is actually cool because they're looking at transdermal estrogen also. So they are only, I think 4 years into it. So far they haven't seen any benefit, but I think you really need a longer period of time, right, to see if there's going to be any benefit or not. So I would actually, but with all the other data, data that we've seen, if a patient has a family history of cardiovascular risk, if they have a family history of dementia, osteoporosis, I would recommend it.
What are the thoughts about this is my situation? Because I didn't do it right away because I was considered at a higher risk for breast cancer. I waited, but I had some quality of life things that weren't getting in my way.
Right.
I had some depression. I couldn't sleep. I was trying to work. So I went on it for about 5 years. And then we just had a hard time kind of figuring out how much I would have in my system. For some reason, in my blood test, it wasn't showing up. So I started to bleed, and so we had those follow-up tests, and my doctor had me go off of it at the time to stop the bleeding.
Mhm.
So I did, but I didn't, at that point, when I went off, all those other symptoms why I started it had gone away, and I didn't feel any different really, so I thought, well, why do I need to be on this?
Right.
So I stopped for a period,
Uh-huh.
about a year and a half, 2 years.
Okay.
And then recently, for cardiovascular health, for bone health,
Mhm.
and for reducing the risk of dementia. My father has dementia.
Mhm.
My doctor suggested going back on it.
Mhm.
And I did for about 4 or 5 months, but I was having these migraine headaches. I was having some difficulty. So then I went off again,
Okay.
and this has been now a couple months. I'm 61.
Okay.
I'm gonna be 62. So my question, I guess, is, and what I'm struggling with, because I've heard that it can be detrimental if you started later or if you go on it being older.
Right.
And I'm kind of in this place now
Right.
where should I go back on it, or is it gonna be more detrimental? And if I do, I'm trying to decide whether to go back on it.
Right.
So, is there an age factor? Is there a problem because I've been on it and off of it to go back on again?
Right.
So that's a lot, I don't
Right.
know.
So it's like, question is like, when were you menopausal? When did you hit menopause?
So, early 50s.
Early 50s, okay. And then how long were you on the hormones before the?
Before I had that break, before I had
Yeah.
the bleeding, about five
Oh, 5 years, yeah.
So because she couldn't, for some reason, my blood wasn't showing the increases she was looking for. I know we had to go to the urine test. I think it was the urine test, or I can't remember how we did that. It was an alternate way of doing that. But somehow we got too high in estrogen. So
Yeah,
that's why I started to bleed.
right.
And so.
So I guess we would have to look at those levels, but I mean, like, if your levels are like high enough, I would say that that's kind of like a form of kind of extending, your age of menopause or whatever, so that, so you would still be within the 10 years. So
Because I did have the therapy, you mean?
Right.
And
So,
one thing you could do too for women, yours is a little mixed
I know.
picture
we
because
have
you've been
to-
on, off,
we
on,
have to
off,
take
and
a
you're really
closer
not that far beyond menopause in the first place. But one of the recommendations that Dr. Blooming recommended is assess, deal with everyone on a personal basis and assess each patient's cardiovascular status. So we have advanced lipid testing, you can get coronary calcium scores, you can get carotid artery ultrasounds, and see, well, who are we dealing with? And
I will
all
add
the
that
overall.
piece to the story for you, and I
Oh.
don't need to take up everyone's time. But I had, for some reason, developed some severe palpitations in November, and I went through a period of time that I was having severe palpitations. I do have low thyroid. But I did the whole thing with the cardiologist.
Mhm.
I am, like,
Perfect.
even though I've found out that I have a genetic predisposition to higher risk of the cardiovascular,
Uh-huh.
I'm
Great.
clean.
Genetic, meaning your
That's
family history,
fantastic.
or they found some gene test?
In the gene testing, I have some gene. But I came out wonderful.
Good.
They did everything. So my risk is like lower than low for that
Right,
piece.
yeah. So
But I have osteoporosis now,
and
and
so.
then the concern about the dementia.
Right, so I mean, the osteoporosis alone would be a reason to put you back on it, because there's nothing as effective as the hormones for osteoporosis. Because the thing with osteoporosis too is it's not just, I mean, we use the DEXA, which is the bone mineral density testing. It's not a great test, but it's the test we have. But what it's looking at is it's looking at the outer shell of the bone. But really what you're worried about is kind of the strength of the bone. And there's really, unfortunately, no way to test that, which is why the DEXA is the best test that we have. But again, it's not perfect. If you did something like fluoride, which totally boosts up your bone density, right? It builds that outer shell. but your risk for fracture is actually higher because that's not all that the bone strength is about. You need the trabecular bone strength, and that, hormones are the only thing that's going to do that. All this other stuff, the bisphosphonates, Evista, calcitonin, the Prolia or Forteo, all these other medications, those are just aimed at increasing that bone mineral density. So, you're not necessarily improving your risk for fracture.
Right, the bones look good on the x-ray, they look good on the DEXA, but they don't have the resilience and the flexibility that healthy bones do, and they snap easy.
Thank you.
So, as we heard, hormone replacement therapy can prevent cardiac vascular disease.
Right.
But in general, as we knew, who should not take estrogen and progesterone hormone therapy. One of the considerations is if a woman has heart disease, then one of the considerations was not to take hormone therapy. There was in general we knew. So what?
Right. So actually, there is a big a study, a randomized control study called the HERS, and in that study, what they did was they had about 2,600 women, 1,300 in each arm, and they were looking to see if there was secondary prevention, meaning after someone has had some evidence of cardiovascular disease, either they've had a heart attack or they've had angioplasty, or stents put in, or a bypass surgery. So they have known cardiovascular disease. They wanted to see, would giving you hormones then, protect you from cardiovascular disease? So they were not able to prove that. There was no decreased risk for future cardiovascular events, but there was no increased risk either, except for actually year one. Like when they looked at the study as a whole, like over the 4 years, they found no difference. But in year one, they did see an increased risk your risk went from 2% to 4%. So, you're looking at 57 versus 38 women. So, is that I guess women would have to take that into consideration to see, based on their symptoms, if they, and I have a patient like this who's having like just horrible quality of life. And she has had evidence of that, so I said, okay, well, here's your risk. In year one, your risk may go from 2 to 4%, but then after that, there's no increased risk.
And she gets the benefits.
Yeah. Well, and so the benefits though would be,
Quality of life.
the quality of life, obviously, and then osteoporosis protection potentially. But I cannot say that putting her on that though would decrease her risk of cardiovascular disease moving forward. But I'm not increasing her risk either.
I have a question. Some people cannot take hormone therapy.
Yeah.
And what would you tell them? Because then it leaves us at a higher risk for cardiovascular.
Mm-hmm.
But some of us cannot take the hormones because it gives us other effects.
Yes.
So I'm just curious on how to, get around that. Because some of us just can't take estrogen.
Right. Well, I mean, other things that can be done for like cardiovascular disease, for instance, is I think Dr. Elthorpe talked about heavy metal chelation last lecture. So that that's where I would go. And then obviously
Just have a good diet.
Right. I mean, our foundations of diet, exercise, sleep, stress reduction, high quality vitamins, because actually the combination of the high quality vitamins and the chelation are shown to have even more of an effect. It's a
Synergy.
Yeah, synergy. Anything else?
Well, and then the other question, and you may have explored all this, but it could be that maybe you're okay on estrogen, but really the progesterone didn't agree with you. That's actually more
It was
common.
actually
The other
opposite.
way?
The
Okay.
progesterone was good,
Great.
but the estrogen, I just couldn't take estrogen.
Because you don't have to consider just both. You could consider one
So
or the other, and
hormone
testosterone, DHEA, other hormones too. But there are sometimes, difficult situations like that. We have to personalize
Right.
recommendations.
I'd like to dovetail on that because that's the thing. I don't think I feel as good on, and I don't know
Oh,
which one is or if it's the progesterone one. This last time is the first time I took the oral progesterone, and I just felt different. I didn't feel that good.
Okay.
So that's part of my hesitation, and just to tag on to hers is, and when I was a young person, like birth control pills and things like that, I couldn't take them. I was very sensitive.
Yeah.
So that's a piece of my question too. Is
Right.
it that are there some people that are sensitive that
Yes.
don't do as well, and how do I know if that is the case?
Right.
Or you, for example, how do you identify that?
Right. So you try, there are different forms that can be tried, different doses that can be tried. But yeah, unfortunately, there are just some women who just don't feel good on it. So then obviously, I wouldn't recommend it for them because you have to feel good, right? That's why we're doing it. So, yeah.
Oh, I just had a quick question. Dr. McCullough and other leading doctors in holistic medicine recommend a Dutch urine test. He said it's a much more accurate read than blood, and they've also said that blood is not accurate. I may be deleted from this tape, that's okay, but my experience was very unusual. I never had any symptoms of menopause,
Okay.
no moods, nothing. And I was very fortunate, but I've always tried to do the best I could taking care of myself. Maybe that contributed to it, I don't know. But when I did finally take them at age 70, I had horrible side effects. And I tolerated it for 6 months with 16-pound weight gain in 6 months and bloating beyond description. I was down to eating 1 meal a day, exercising, couldn't lose a half a pound. I diuresed all that weight in 2.5 weeks when I went off.
Yeah.
So it's so confusing for the average person.
Right.
And I'm wondering if more research needs to be done into this Dutch urine test, because when I paid $250 to have it, all my hormones were normal. That was after I went off of them. So obviously, it was too high of a dose for me, but another person, they may need it, I understand that. But not everybody's created the same. And I was told the blood, by the practitioner that did the Dutch urine test, the blood is not accurate. So of course they were low in the blood, but in the tissues is what really concerns me. If you're having high levels of estrogen in your tissue, that's not a good thing. So for me, I literally looked like I was 7 months pregnant. My husband said, I was so bloated and couldn't tolerate it anymore, so I went off, took myself off. I just come to a happy conclusion. It looked like from my Dutch urine test that I need a little bit. So I just cut the doses way down, 20 milligrams of progesterone, a tiny bit of estrogen. It's very hard to do because it dries up from the tubule. But, I'm trying to manage the best I can with both viewpoints on it.
Right.
But I don't think everybody needs these high doses. I'm one of them. I just exploded with horrible symptoms. And I felt so badly. I was exercising and kept gaining 2 or 3 pounds a month.
Right.
So it would be interesting to do more research into what Dr. McCullough, Dr. Zand, and a lot of naturopaths have done and find out whether this Dutch urine test would benefit people like myself, which it showed there that all my hormones were normal. My skin was breaking out, an oily skin. It was just horrible symptoms. So, I just had to do what was best for me through research, and it may not work for everybody, but especially someone that doesn't have any symptoms. Maybe they just need a real low dose, and maybe it's helpful, I don't know. But it's something I think that needs looked at, and maybe I'm an isolated person.
I've actually had a couple of patients ask about the Dutch urine test, and I'm not familiar with it, are you?
Not very, no.
Yeah, because I know that, the data that's out there, they do provide kind of, guidelines, ranges for blood levels. Having said that, they are guidelines. And so, I have plenty of patients who are like super low hormone doses, you know, and even though they're not really, their blood levels are really low. I mean, so whatever lab you choose to look at, you really have to go by your symptoms and your side effects.
I think from what I've learned, your symptoms are more indicative of what you need.
Most
than your blood.
definitely.
Even though my blood shows low, I was told that this is outdated, the blood is outdated on hormones, you need a dry urine test. So it remains to be seen. That's just my personal experience, and I know a lot of women do benefit from them, but that's just an unusual experience, I guess, not that common.
Well, it wasn't, yeah, it sounds like an unusual experience. But one thing I'll say about tests is that there's no perfect test. And I've practiced with saliva testing
Yes.
and blood testing. And a test should always be looked at as guidelines and tools, not the answer, because there is no laboratory test that's going to tell us how your cells are responding to the hormones, right? Because the hormones are chemical messengers, and the way they affect the cells varies immensely from one woman to the next. So that's why when we even look at blood levels, we know there's a pretty large range of normal, you know, like 30 to 150, sometimes more. And so it depends on what your cells are experiencing. And if you had gone a long time with no estrogen exposure, your cells hadn't seen estrogen for a long, long time. And so the receptors were very lively, they were very hungry, and very easily affected by small levels. And yeah, you probably just got overdosed. Yeah.
Yeah, the dose was too high. I've talked to 4 or 5 other menopausal practitioners, and they told me no more than 50 milligrams of progesterone, I think, a milligram, I'm not sure, of estrogen. So when I started to take close to that, not as much, I mean, I don't feel any different, but I feel at least I'm doing maybe something close to what I should be doing. But with the severe side effects, especially the BHRT, I was on way too high dose and had
Well, that's where you're getting the oily skin, yeah.
horrible reactions. And a dermatologist finally told me, "Are you on BHA?" And I said, "Yes." And they said, "That's what causes it."
Right.
So hormone replacement therapy have shown not to increase breast cancer.
Correct.
So that is a very good news.
Yes.
But what about women has a high risk of breast cancer, like having a family history,
Right.
like mom and sister already passed away from breast cancer.
Right.
So what do you think, doctor, about them feel free to get this treatment?
Dr. Blooming actually did reference one study that looked at women with BRCA that were actually BRCA positive, you know, the gene testing,
Oh,
they
okay,
have the
yes,
breast
yes.
cancer gene, and they didn't have an increased risk. Now, the data on that is probably not going to be as large, you know what I mean? Like there's probably limited data, but he did reference that one study that it's not an increased risk. Yeah, and I wouldn't, family, if you have a large family history, I guess I would get genetic testing. I just think that there's not enough data. Like if you wanna, you know, if you're looking for studies, they're gonna be relatively new because even, you know, genetic testing is relatively new too. So, yes.
Just a request from the audience. They can't hear our live audience, so if
Okay.
you could just summarize and repeat the question, that'd be very helpful.
I'm sorry, okay.
Thank you.
So that last question was, what about if you have a family history of breast cancer in multiple members? How does the data relate to that? That was the last question.
And also, that is not relate how long take hormone therapy, like as I knew, not longer than 5 years,
Oh,
then
yes.
more safe, then
Okay.
longer.
There's actually no data supporting that recommendation. So that recommendation was kind of made, I believe, as a compromise. That's what, you know, like, so if you, I'm sorry. So the question is, is taking hormones for a shorter period, like 5 years, is that safer than continuing longer? And so I think that recommendation came from kind of, the people who are really kind of the people who support the WHI, the people who don't feel comfortable prescribing hormone replacement therapy, I think that was kind of their way of saying, okay, we know that it helps with quality of life, but we still don't believe it's good for you. So just take it for, the shortest amount of time necessary, the lowest dose. But there is no data to support that. And if anything, we know that like protection against dementia, protection against osteoporosis, cardiovascular disease, these are things that you will lose once you stop the hormones. So there's really no reason to stop the hormones. I mean, unless you're not feeling well, obviously. But if you're doing fine, there's no reason to stop the hormones.
I have a question from our online audience. What studies are available that show that estrogen alone is safe for those of us who have bleeding problems with progesterone?
Bleeding problems with progesterone. So the problem is that if you're taking estrogen alone without the progesterone, you're putting yourself at an increased risk for endometrial cancer. And that has been proven, like that's like
4 to 8 times.
that's not controversial at all. So in women who aren't tolerating progesterone, actually there's plenty of data. If you want to look at the data looking at estrogen alone, I think there are probably better results from studies that are looking at estrogen alone. And so sometimes there's this question of, well, is the progesterone then dangerous, and I don't think that's the case either, because there are plenty of studies that show that the combination still provides you these benefits. But if your only problem is bleeding, I would say after a workup, obviously, you want to get an ultrasound, probably an endometrial biopsy, make sure that there's no hyperplasia, which is a precursor to endometrial cancer.
And what are your levels and what type of progesterone are you on, right?
Right. So once you've ruled any pathology out, then you could probably do something like an endometrial ablation, or even a hysterectomy. That's a little severe, but sometimes that is necessary if you want to continue your hormones. But anyway, in terms of, I guess the original question was like, what studies are there? I would refer you to Dr. Blooming's book, because again, he has, it's a very well-referenced book, and many of those studies do look at just estrogen alone, and there's plenty of data that shows that it's, it provides the benefits that we've talked about.
If the doctor prescribe a natural progesterone instead of synthetic progesterone, is that okay, allowed to get hormone therapy treatment, having stroke or blood clot problem woman?
So
Repeat that.
are you asking if a woman is prescribed natural progesterone instead of Provera, if that is safe if you've had a history of stroke or blood clot
problem,
right?
Disease.
So actually, the progesterone, natural progesterone, has been shown to not increase your risk of blood clots versus Provera that has. So yes, so I would feel comfortable prescribing progesterone in someone who's had a blood clot. Stroke, I would have to look at the data for increased risk of hormone therapy in someone who's had stroke, actually. So we have seen that there's no increased risk if you've started it earlier on, but I am not familiar with the data looking specifically at if you've already had a stroke, like I'm familiar with the data on if you've already had a heart attack. So that's something to research.
Another question from the online audience. What are the side effects of taking too much progesterone?
Side effects of taking too much progesterone, it's going to vary by woman, sedation, like feeling groggy in the morning. But we do have patients who, you've heard from here, patients well, you tolerated the progesterone fine, it was the estrogen. Some patients have bloating, they have depression. Actually, I had a patient who had depression from too much progesterone. Yeah, I guess you can. Even though you would think progesterone should decrease the breast tenderness, it can also do the opposite. It can increase. But I would say usually more bloating, weight gain, and moods actually are probably the most common side effects, in addition to the grogginess.
Thank you.
Bioidentical and both synthetic and bioidentical hormones, they say there's no difference in the cancer rates according to breastcancer.org. What's your feelings on that?
Okay, so the question was, breastcancer.org says there's no difference between bioidenticals and non-bioidentical hormone therapy in terms of breast cancer rates. And I have to say that's true. Like if you're looking at the WHI, they use Prempro. So that's why I like pointing to the WHI and saying, this is like the worst possible scenario. You have women who aren't healthy and they're on Prempro, and it still didn't show an increased risk of breast cancer.
What about the effects of iodine in the breast tissue? Would that help mitigate that?
Well, the iodine does, it does help with like breast cysts, but I mean, are you asking for like, does it decrease risk of breast cancer?
Yeah, I've seen some studies from Dr. Brownstein on PET scans when he increased the iodine levels, give him like 65 milligrams, 40, 65 milligrams a day. He has PET scans showing the breast tissue healing, but the cancer's being destroyed from the inside out.
Interesting. I'm not familiar with that data.
Yeah, they said that it helps maintain the structure of all the reproductive organs.
But you're talking about PET scans of patients that already
Patients
have
that
breast cancer?
and you put them on iodine, high dose iodine, like 40, anywhere from 40 to 65, like 5 pills a day, and that seemed to break up the cancer tumors in it. Without it, it says the nation is deficient in iodine.
Yeah, that's
And
true.
that's other possible reason why people are getting it. Maybe not, it's not the hormones, maybe it's the iodine deficiency.
So the question was, does iodine decrease the risk of breast cancer? And so Dr. Meric and I will have to research that.
That's cool.
But yeah, I mean, we don't know what causes breast cancer, right? I mean, no one knows, it's multifactorial. But we know that hormones do not increase the risk of breast cancer. So.
The moment's idiopathic.
Right.
I have a question. Does it matter, we're talking about taking different levels of the hormone replacement, so some taking a smaller dose, some taking maybe a larger dose. Has that been factored in? Is there like a certain level, blood level that you're supposed to have to get all these benefits? Or if you take just a little bit, will you still benefit? Is there anything regarding that?
I mean, like there's some data looking at, what was I just looking at? Talking about like kind of minimal estrogen doses that would maybe confer protection against osteoporosis, for instance. So, but again, those are guidelines. So, you're not going to take any more than you can really tolerate. If my patients are doing well, but their levels look a little low, usually if I'm doing a well woman exam, like even with a normal estrogen level, I can tell when I do your PAP that you don't have enough estrogen on board. So, I would increase your estrogen as long as you're tolerating it. Yeah. But so it's hard to say, like, so if you need to go lower than that because that's all that you can tolerate, how will that affect you? We would only know by, checking a bone and, following up on a bone density in a couple of years.
And I know the 100 milligrams of the progesterone, they've shown protects the uterus. And that seems like a standard recommendation for that. But again, how do you determine that ratio when you recommend for someone of the estrogen and the progesterone?
Yeah, so the question is, the last question was if you have to take a lower, is there any data on like what doses are protective for different things? And unfortunately, not really. And then the second question was 100 milligram progesterone is it has been shown to protect the uterus against endometrial cancer. But how do you know, like, you know, if you have more estrogen, or if you're using higher doses of estrogen, how much progesterone you need? I personally don't use a ratio. I kind of like to see my levels in a certain area. But also looking at how if you're having any bleeding, and then looking at an ultrasound, and then if the ultrasound is showing any thickening, doing an endometrial biopsy, that's really the only way to know whether or not you're having true protection. I mean, I have had a patient with like high progesterone levels still ended up with endometrial hyperplasia, and so there's nowhere to go from there. We had to stop her hormones.
I have another question. When estrogen levels are tested 3 times higher than they should be after taking estradiol, is constipation a side effect?
I haven't seen that.
Yeah, I'm not familiar with that.
I guess for a given person, it might be pretty obvious.
Mhm.
Never had that problem before, and then when their estrogen is high, so it's possible, but it's not a real common.
It's not one of the common things.
Okay.
Okay, shall we go on to the next set of questions, and then we'll do more free question and answer. So the second page starts out with true or false question. In 1992, a prospective randomized study, estrogen therapy was shown to be associated with a 0 breast cancer rate in 168 women, while there was an 11.2% breast cancer incidence or rate for women not on hormone replacement therapy. Is this true? So basically, they had 168 women, and of the women that were on estrogen replacement therapy, ERT, 0% or 0 women had breast cancer in that group. And the treatment group, on the placebo group, the women not on active hormones had 11.2% breast cancer rate. It was actually a true study, and I think it speaks highly to against this idea that breast cancer is caused by estrogen. I mean, that's a perfect example of how it looks like it protected those women. Certainly didn't make it any worse. Couple of things to mention in this description. A prospective and randomized study means they assigned proactively ahead of the beginning of the study. They said this group of women will be on estrogen replacement therapy and this group of women will not. And they usually look to see that there's no difference between those. Like, we wouldn't want all the obese women on estrogen or not on estrogen. We wouldn't want all the smokers on or not on. So they try to even the playing field. And then prospective means we're going to follow the outcome going forward in time, which is always more accurate than looking at a study of women who already have breast cancer and then looking back who took or didn't take estrogen. So this was a really strong statement. It definitely gets my attention. The next one, true or false? Estrogen therapy by patch or topical cream increases clotting risk. Right. We've talked about this. So it may be some effect of the oral estrogen on the liver clotting factors, but if we put the hormone directly to the bloodstream through the skin or vaginal for that matter, then we don't have that concern. And next, true or false? Women without a uterus, so women who have had a hysterectomy, don't need progesterone therapy if they're going to take estrogen therapy. Is this true? It's false. Right. Do you know why?
Because you need both hormones for balance.
Right. Balance is important. And progesterone just in and of itself is anti-depression type of effect, anti-anxiety for sure. It's a fat-burning hormone. It puts us into fat-burning mode. Estrogen tends to tell our bodies to store fat. That's why women have more fat stores than men on average. But that's to help with lean times and pregnancy and carrying a baby and nursing and all that. So we have extra fat we can live on. And then the progesterone discourages water retention and promotes good sleep patterns, and it's a direct bone builder. So testosterone and progesterone help build bone, and estrogen slows down the natural tendency to break down bone with time.
And progesterone also has a neuroprotective effect as well.
That's right.
So.
Yeah. studies with acute brain injury actually have been shown to patients get better with progesterone acutely. Next one is true or false. In a 1994 study, Robin Gorski at the University of New Hampshire showed that ERT, estrogen replacement therapy, was associated with 4 additional years of quality life in women taking estrogen replacement therapy for 25 years. Do you think they found that? 4 additional quality of life years? They did, actually, yeah. And for 25 years, that was a really nice long study, very impressive quality of life benefit. And true or false, a prospective study published by Don Willis from the American Cancer Society, sorry for the abbreviations, the American Cancer Society, showed in 1996 that over 422,000 women, a little over that, but I didn't want to put all the numbers there, over 422,000 women who had ever taken estrogen had a slight decreased risk of dying from breast cancer. Do you think that's true? It was true. So talk about numbers. That's an amazingly large study showing, if anything, that the estrogen replacement therapy patients had less breast cancer than the women not taking, had less death due to breast cancer. That wasn't an incident study. That was a cause of death study. But that's super important, right? Because what we really care about cancer is how is it going to shorten our life, right? Next is true or false. Masahiro Takuchi of National Cancer Center in Tokyo showed in 2006 that 9,000 women on estrogen replacement therapy were less likely to develop breast cancer than never users, than women that never were on hormones.
True.
It was true. Yep. Another very strong statement to give us a comfort level with the estrogen replacement therapy in breast cancer. And lastly, true or false, the North American Menopause Society, who sets forth practice guidelines, did they recommend routinely stopping estrogen replacement therapy after the age of 65? No, they do not. They actually have a statement that says there is no age by which we need to withdraw, and that's what one of the participants was saying before. Yeah, that's not indicated. And then in Dr. Blooming's book, he actually listed all the different worldwide societies, medical societies of different types that support that idea too, that there's no need to withdraw it, and there must have been a list of like 30 societies. It was amazing. So, all right. What other questions do you have, or in the audience at home?
I have one about the progesterone. Sometimes there's a recommendation to do 15 days on or 15 days off. Sometimes there's a recommendation to take it every day. What determines that, or what's the difference between doing one versus the other?
What's more natural? Oh yeah, the question is how to take progesterone. Should we take it for 2 weeks on and 2 weeks off, or should we be taking it all the time, and why are there differences and what are the factors? So basically, if you want to talk about what's the most natural way for your body to experience progesterone, it would be for 2 weeks on and 2 weeks off each month. Because when we're making our own progesterone, we make it after we ovulate. So we have pretty high levels of progesterone from ovulation till right when we're starting our menstrual flow. And the reason we start the menstrual flow is the ovary can only make progesterone for about 2 weeks, and then the hormones start to fall. As the progesterone's falling, then the menstrual period comes. So that's, if you want to try to mimic how your body was dealing with progesterone premenopausally, then it would be 2 weeks on and 2 weeks off. I have a mixture of patients. Sometimes they decide to go on it daily, some out of convenience, some to avoid a menstrual period, because if you have enough estrogen on board and you come in and do progesterone 2 weeks on and 2 weeks off, it's about a 60 to 70% chance that you're going to stimulate a menstrual flow at the end of each progesterone phase, 2 weeks on and 2 weeks off. But it's not concerning. It should be not light. It should not be heavy. It should be light and not really painful, and it should last just a few days, usually shorter than a woman's natural cycle, and it would happen at the end of the progesterone. So this wouldn't be worrisome kind of bleeding that's happening all over the place. And if women do elect to take their progesterone all the time, which some do because they realize, oh, I have less anxiety, I sleep better, and I look forward to the 2 weeks when I'm on my progesterone, and do I really have to go off? So sometimes they'll take it for the benefits of the way they feel. But when we give it that way, we do sometimes run into this problem with bleeding on progesterone. That's a lot more likely to happen if we're taking continuous progesterone. It does tend to thin out the lining, like Dr. Mitchell was saying. We want to look at levels, we look at endometrial thickness on the ultrasound and try to manage that. So, any other factors you can think of?
A lot of women just don't want to have a period
Yeah,
anymore.
right, they're trying
That's the
to
main thing.
avoid it.
So is this thing, when we take estrogen, progesterone, daily, every day, instead of 15 day on, 15 day off, then may more risk of heavy bleeding?
Not
Well,
necessarily.
it's not necessarily heavy bleeding, but sometimes it's sporadic. It's usually very light, but it's just a nuisance.
But I
who
would
wants to
say
be
that-
bleeding on and off?
But I would say that most of my patients don't have, that's not an issue.
Correct, right.
Yeah. And if you look at the data, there are no studies that show that one regimen is better than the other.
Right. But we do recommend two weeks of progesterone exposure treatment every month for the protection of the uterus. Anything else?
And then, of course, if you're more perimenopausal, I guess probably in that population, I would tend to use a cyclic more. But then I do have a lot of women though who do like how they feel when they're on their progesterone, so then they just choose to take it daily. I think the irregular bleeding that you might get on the daily progesterone is probably more common in the perimenopausal women, the women who haven't gone for the full year without a period. So that might be a little more irregular. So, you just kind of try it, and then if they're bleeding all over the place, then we say, okay, let's just do the 2 weeks on, 2 weeks off.
Could you do that at any point
Yeah.
if you decide to change it up?
Sure.
But it would be recommended, say for instance, take my case, if I went back on it, it would be probably best to start the progesterone and the estrogen at the same time, do the 15 days and then go off the progesterone. Or does it matter?
It's a totally individual decision, I think. That's kind of how, yeah.
Which order?
Sorry, that question was, so she wanted to know if she should start, just the 2 weeks on, 2 weeks off, and it really is an individual decision.
So how do you guys feel? Is this like new news? Does this make you have a better comfort level, or at least open up your mind a little bit? Still have worries?
Any other questions from the audience at home?
We had some questions from the audience at home that were actually answered. Looks like Dr. Eltham and Dr. Core were answering some,
great.
and
Thank
some of
you.
the same questions from the audience
Okay.
here. But Dr. Eltham did mention to mention that we'll be doing this again next month, the second Thursday of the month, and next time it'll be Dr.
It's Tim.
It's
Priya Patel, and she's going to be talking
And
about
Dr.
the importance of
also.
gut health.
Yeah.
Maybe just
Oh,
Priya,
yeah,
it may be P.A. Patel. And, but it would be gut health, and the date, I looked this up before and I forgot, is the 10th, October 10th.
October 10th. And she's also mentioning that we can ask the audience what they'd be interested in hearing about. Doesn't have to just stick to that.
Thank you. I'm glad she's on.
Thank you, Dr.
Yes.
Elthorpe.
We see you're doing great.
Any topics that you guys would be interested in hearing more about?
About help for men, to hormone replacement for men. I heard some of these
Okay.
guys are getting testosterone replacement. I don't know, what's the risks versus benefit?
Okay, yeah, that's a good one. We haven't done that yet.
No, we kind of did a general hormone where we did touch a little bit, but now that we've dedicated a whole session to women, maybe we should
To give it
dedicate
an
a whole
audience.
session to
Okay.
men.
Sounds good.
I just have a comment. It's about, because they were talking about how many hormones they have in the ovaries. They said they don't know exactly how many we have in there. So they said it's,
Never know. Yeah.
I just found that very interesting when they were talking about how we have more than just estrogen, progesterone, and testosterone. There's a bunch more that we're not even aware of.
Right.
Right.
Yeah. So,
So hopefully do more research on that.
Right. But I think we know a lot and we can
Yeah.
help, but yes, definitely. Not everything has been discovered.
And then, actually, so Linda, our nurse, brought up that there's some legislation going on where they're trying to stop compounding pharmacies from compounding hormones, which is unfortunate. I think there's definitely a place for compounded hormones. I think that sometimes there's a question about standardization, but as Dr. Althorpe said, you're following levels and, you're not gonna, it's not dangerous, it's not life-threatening, and you need the flexibility of the compounds, because sometimes, what's available pharmaceutically is just not the dose that you need, especially for you women who need, much lower doses. You won't be able to achieve that with what's available pharmaceutically. So, or even or higher doses, what are you gonna do, wear 3-4 patches at a time? So it's nice to have the option of compounding. So, I think there's these cards here.
In the Professional Compounding Centers of America, I don't think everybody got one of these. They have a website, it's savemymedicine.org.
You have to be filmed.
Lynn Talon can have it for me. Some people got it, but some people didn't. But you can go on the website and receive the information just by visiting, or you could sign up your email to get notification when there's something big, like some piece of legislation, that you can become active and try to, defend your options, because the big pharmaceutical industry is really trying to make it all their game. So it's at savemymedicine.org. What else were we going to mention? Oh, we have our doctors' great bars are coming back, so we should have them any day now. John said.
I had.
Well, you have one, but I talked to John.
Oh,
We had a little sample.
Okay.
and we like it. It's been reformulated by another company that's doing the formulation for us, and it's really good. It's more creamy, it's softer. How many people have tried the doctor's great bars? We have, but they're very good. We designed them with something called phospholipids, which are really important in rebuilding your cell membranes and improving energy, improving the health of the mitochondria, which is the little organelles inside of our cells that we make energy with. We did studies on ourselves showing what happens to us when we're eating like a typical brand name bar, like caramel sea salt bar, versus what's happening to us in our blood levels when we eat the Doctor's Great Bar. And the Doctor's Great Bar has so many grams of fiber that it basically leaves us with not many carbs. We call it net carbs. So we don't have a big blood sugar and insulin spike. And I forget the exact data, but something like there's 55 times the insulin spike in patients after, or ourselves, which we were the patients, after eating the typical bar versus the Doctor's Great Bar. And the blood sugar was also
4 times.
way different, 4 times or something like that. So really excited about it, and we feel like, the new bar is going to be even better, because if it's formulated and tastes better, then more people want to eat them. So.
Yeah, but we were, we wanted to provide a healthy option because the bars are used a lot. They are super convenient. But if you look at the profile of most bars out there, they're horrible. So ours has like 14 grams of fat, the good fat from these phospholipids, 15 grams of protein, 15 grams of fiber, and only 2 grams of sugar. So it's, you're not going to find a better bar out there.
Right. And it's satisfying because of the fat and protein content. And so you don't have to eat as much. Last one. Yeah. You're not, she says she's not hungry for hours after she eats one.
They're very good.
Yeah. And
so when are they expecting the bars?
like literally, John was
Any
in
day.
here, he said tomorrow, the next day, well, tomorrow's Friday.
Try next week.
Hopefully.
They could be in tomorrow.
Yeah. And what else was I gonna say about the bar?
Where do you get them? Right here?
Yes,
The
in our
supplement
supplement
suite?
store. Yeah, and you can order them online too. What's something about, what they, for those of you who haven't tasted them, they have chocolate, coconut, and almond, and chicory. Those are the basic flavors that come through in bars. And then eventually we'll make some different flavors and have fun with it. Right. Anything else before we say goodnight?
And hopefully they make one with less fat.
Why is that?
Oh,
Because it's, because sometimes heart patients really have to be careful on how much fat they get in their system. So if they could.
So we disagree with that, and that's a whole different topic. Actually, Dr. Ellithorpe, were we
yeah.
recording?
That is a great topic. Like the whole
The
fat.
whole fat idea,
Yeah.
She talked about that yesterday on her.
Oh,
There-
okay.
Oils.
We gotta read
She
her,
did the clinician's oil.
Actually,
Yeah.
the worst
Her
thing
live
they
stream.
can
Right, oils,
do
that's a
is,
great
we
one.
gotta look at the live stream.
say that
So,
we should
but we do
look at
disagree, and we
that.
can share that with
For
The
our
whole
brain and
saturated
for our
fat
health.
thing.
Yeah.
There's a,
Or cholesterol.
Too long, but
a
I'm
doctor.
talking about from the heart patient's perspective.
Yeah.
Yeah,
So.
But we find really what happens is that you can affect the cholesterol profile in a beneficial way a lot more effectively by cutting carbs than cutting fat. And cholesterol, your liver makes so much cholesterol per day that it's actually kind of a antiquated idea to cut your cholesterol out of your diet, thinking you're going to make a difference in your serum cholesterol. So, but that would be a great topic.
Yeah, I think that would.
But don't be afraid of fat. We're
Yeah.
not fat phobic. Fats are
Like,
good.
then you have the trans fats, which,
Oh,
right.
Ellithorpe says to
Of
stay away
course.
from certain
Right.
oils.
Yeah.
Yes.
Yeah.
So.
Did you have a question, sir? I'm sorry.
No, I just said I would beg to differ with that,
With what? The fat idea?
yeah, let's discuss it some other time.
Yeah, we need to do it, yeah.
I'm a patient,
Okay.
and I've done it both ways, and I see the results.
Oh, okay.
I'll put it to you.
Well, yeah.
Okay, yeah,
No,
bring your
and that's the
experience.
other thing with, everyone, it doesn't work, like our recommendations aren't necessarily gonna work for everyone.
Right.
Like, we realize that, so you have to, you try it one way, and then if that works, if that doesn't work, great, you try something else.
We also just had a few recommendations from the online audience for future topics. Hormone imbalances in younger women, painful periods, and PCOS,
Mhm.
and endometriosis.
Okay.
Okay.
More GYNs, okay.
Yay.
Dr. Althorpe says to remind everyone about our weekly Q&A, Wednesday mornings, 9:45 a.m. to 10:15 a.m. Shorter version, just a doctor asking your question.
That's a idea.
Everyone's in line.
That's cool.
Thank you, ladies, for your time.
Thank you for
Thank
coming.
you, yeah, thanks for
You
coming.
do a men's one?
Yeah,
Yeah,
no,
that's
that's on the list.
Yeah.
Because
Did you write it?
I did. Thank you, good night, everyone.
Thank you.
I don't know, you guys go.
I'd be surprised.
Thank you, thanks for coming. Thank you, thanks.
Thank you.